Good evening, everybody, and welcome to another of our webinars. This is on concepts, perceptions, and mechanisms of pain. Your host this evening, once again, is Martin Harvey, and I'll pass you over to him in a minute or two. But before I do, I just want to make you all aware that this webinar is being recorded. And also, if you would like to ask any questions at all, please do so by putting them in the chat box. So I will hand you over to Martin. Thank you.
Well, thank you, Jill, and good evening to everybody. Thank you for joining us. It's something that we probably come across a lot in our job, pain, either on purpose or otherwise. And somebody says, oh, that hurts, stop doing it, and so on and so forth. So I thought it might perhaps be of interest if we looked at pain in a little more detail. Now, what we plan to do is we plan to have a pain series. So I'm going to start the series off, and then we've got some far better speakers and far more knowledgeable people than me, who hopefully will continue the series. We'll be looking at specific elements, specific parts of pain. So what I'm going to do is give a bit of groundwork, a bit of the ground perceptions of pain, possibly revising a huge amount that most of you already know, but also perhaps giving you a couple of things that you might want to consider and think about that you may not currently be familiar with. So, pain. Well, we are supposed to be scientists. Well, that's what it says on our degrees anyway, however true that is. So I suppose we really should approach it in a scientific matter first, and we should perhaps look for a definition. And when I can actually make this presentation work, that works, there you go. If we can look perhaps at an internationally recognized definition of pain. So the International Association for the Study of Pain defining pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or it's described in terms of that damage, such damage. And they make the point, and I think this is something that we do accept, pain is always subjective. There's a little bit more in their definition there, saying that each individual learns the application of the word pain itself through experience related to injury in early life. So, if we've been beaten unmercifully as a child, then we will probably have a slightly different perception of pain than somebody who has, had quite an easy existence starting off. That was the definition that the International Association for the Study of Pain came out with in 1979, and I think it's still a current definition. So perhaps that's one thing we can accept. There are simpler definitions that we come across. And another one, once again, we tend to use this in healthcare, don't we? That pain is whatever the person experiencing says it is. So, for example, if we look at an event that is possibly painful, that I would imagine it's probably reasonable to assume that that was a painful thing. The animal in question, I believe, was a polar bear. It's quite interesting there to see that the Achilles tendon is still patent. Now, I don't know how this case developed, because fortunately it wasn't a case that came through my clinics, because I'm not sure where I would have wanted to have started. But I suppose there's a possibility that they managed to salvage that limb. If this is it, by the way, if this is any of your patients, this was somebody that you came across, and if you do know what actually happened to them, we'd be very interested to hear. The only problem I suspect is it wouldn't have very much of a patent blood supply, would it? You'd probably have some from the arteries that are running to the anterior aspect of the foot. But I think the posterior tibial artery's gone to hell and back by the look of it. But that good old Achilles tendon is still there. So I suppose the message for that is beware polar bears. However, different eras, different cultures, different professional standpoints they do tend to diverge quite dramatically on how they view pain, how they describe pain, and the terms that they describe pain in, how they cope with pain, how they expect their patients to cope with pain, and also how they treat pain. It's a very, very broad area, and it does vary a lot depending who you speak to and who you're listening to. If we go back into the classical eras, then if you look at Plato, who, as we know, was a philosopher, he considered that pain was felt when atoms of a person suffered alteration, and that pleasure was felt when they were restored to their original, their resting state. It's interesting that the term atom was still kicking about there. Obviously, they didn't understand an atom in those days as we understand an atom. Nonetheless, they had this idea that all things, all matter, all substances were actually composed of things that we actually couldn't see. So it's quite interesting that that was kicking around a couple of thousand years ago. Similarly, another philosopher, Timaeus, he considered that those parts that underwent violent alterations and then were restored gradually and with difficulty to their original condition produced the greatest pains. They had the greatest potential for pain to occur within them. Hippocrates, of course, he of the Hippocratic nail and many other things that we come across in foot care, considered pain to be purely a clue to disease. It was just an indicator that some disease, some dysfunction in the body was occurring. And that probably is quite a modern viewpoint. Then Plato and his Epicureans, they viewed supreme pleasure as the total absence of every type of pain. Whether it is, I don't know. I'm not conscious of the fact that I've ever felt supreme pleasure. But I'm not conscious of the fact either that I'm always in pain. And hopefully it will continue for a long time. But there we are. There's some different viewpoints that, perhaps might put what we're going to talk about as we go through this in a little bit of a context. And then, of course, we have to look at the more psychological viewpoints in faiths. So if you look at Judaism, for example, in the Old Testament, they saw that pain is a test of faith to be endured. Those of you who've read the Old Testament might have come across Job, who apparently, according to that book, had quite a few problems. The trials and the tribulations of Job. In the Islamic faith, they say in the Quran that it may be that you hate something when it is good for you, and it may be that you love something when it is bad for you. Well, yeah, that's quite a modern viewpoint as well, because quite often we love quite a few things that are bad for us. Whiskey and cigars and all the other things that probably aren't as good as they could be. And they say that Allah knows and you do not know. So that's their viewpoint. Then Christianity, of course, has the idea, or certainly had the idea at its inception, that pain is a pathway to redemption for yourself or for others. For example, what they recount as the crucifixion. So that's another viewpoint on it, perhaps. If we come a little further forward, and if we look at a typical philosopher of the Enlightenment, Descartes, then he said pain is an alarm bell ringing in a bell tower. So he very much had part of the classical viewpoint there. But pain was obviously something that the body was using us to alert us to that something was wrong. Once again, very possibly like me, if you're speaking to one of your patients, perhaps you've done some procedure on them, surgery, something like that, and they say, well, how soon can I use this part of the body? Then certainly in my instances, I'll say, well, okay, there's the official viewpoint of how long you should keep the dressings on and so on and so forth. But then be guided by how your body feels. How does it feel to use it? Listen to your body. So if the alarm bell starts to ring, then stop doing what you're doing. you know, if I've done nail surgery on your nail, for example, then don't ram them into your safety boots and just, you know, wear your safety boots within 24 hours of me having, you know, done a wire grads on you or something. So quite a modern viewpoint, perhaps. That's what Descartes told us, or I suppose I should say Descartes. Although my French, having said that, was learned many, many years ago and never could thence, and it's even worse now. We then look at a little more modern viewpoint. We've got an anonymous one that was reported in The Calculus of Suffering, which was published in 1985 in New York. And that is the fact they claim here, and that the men and women and children endured physical suffering, that it was inevitable that they would have it. And that the meaning, rather than the fact of pain, was what mattered to the good life. So, you know, if you had the pain, you were being deceived, you were being, you know, subjected to something that would be good for you. Possibly that's encountered when they say that, certainly in Victorian times, you know, they say, well, okay, go and have a bath in cold water, and you know, we'll hit you with a stick at the same time to make the child better, to improve the child, spare the rod, spoil the child, and things like that. And the greater the pain, the greater must be our confidence in the power and the energy of life. So if you really want a powerful and energetic child, you beat the hell out of them, according to that theory. Hopefully we've moved on a little bit from that. Hopefully. If we then come to much more modern viewpoints, then I'm sure that all of you will be familiar, certainly with the name, possibly even with the work of Dr. Albert Schweitzer. He was a physician, and he was also, of course, a great philosopher, and did a lot of work in other countries, helping to, or trying to help to remedy disease and pain. And he said in 1914, to the millions of people in every country who live and die in needless pain, we must all die, which is true. But if I can save a person from days of torture, then that is what I feel is my great and ever new privilege. Pain is a more terrible lord of mankind than even death itself. So he obviously had quite a definite view of it. And he saw his role as a physician and also as a philosopher in doing what he could to ameliorate, where possible, pain. Then a slightly more modern one, even than Dr. Schweitzer, is Dr. Rene Leriche. And now, if any of you are interested in pain therapies, you might have seen a few of his quotations, because Leriche and one of his colleagues, they were actually one of the first people to start to use local anesthetics as diagnostic tools. I know he published one on nerve root injections, spinal root injections, using that as something that would indicate something about the area that was giving pain, and if they could turn pain off to a particular area, then they could identify what was perhaps originating the pain. And of course, nowadays, nerve facet injections, spinal injections are quite popular, aren't they, in orthopedics? But Rene Leriche said that physicians too readily claim that pain is a reaction of defense. So I don't think that he agrees very much with what Descartes said. But it's a fortunate warning which puts us on our guard against the risk of disease. And then he becomes quite vociferous on it. And he says, reaction of defense against whom? I mean, you can imagine this with a French accent as well. It can be really quite effective, isn't it? Against what? Against the cancer, which not infrequently gives little trouble until it's too late. Against heart afflictions, which always develop quietly. One must reject then this false conception of beneficent pain. And quite powerful words there. And I first came across that in a very good book, The Challenge of Pain, which initially was called The Puzzle of Pain. And that was written by another physician, Dr. Melzack. And Melzack actually collaborated with another Dr. Wall, and they put together another one of the books that I find most interesting, which is The Challenge of Pain. I might mention a bit more about that later on. And these are the people who did it, Doctors Melzack and Wall. And they published this book in 1965. And probably the first reference to this idea that is now quite widely accepted of pain gates. And in this book, which I have on my bookshelf, there we go. So that's the Challenge of Pain. As you can see, it's quite a well-thumbed copy. I think I bought this back in, when was it? Yeah, this is the 2008 edition, and it's been consulted a lot since then, because it does have some quite good ideas in it. And they state that the subjective experience of pain is modulated by large nerve fibers in the spinal cord that act as gates. I mean, we know that pain gates exist in the spinal cord. It was known certainly before Melzack and Wall highlighted it. You have what we identified as the spinothalamic, the spinal-reticular junction, where the peripheral nervous system joins the central nervous system, and so on and so forth. And they say that pain is not the product of a simple transmission of stimulation from the skin or some internal organ to the brain. That sensations from stimulation impinging on pain receptors have to pass through these spinal gates, as they describe them, to the brain in order to emerge as pain perceptions. And actually, there's something quite interesting behind all of this. The status of the gates is subject to a variety of influences, which could be drugs, it could be injury, it could be emotions, it could be instructions coming from the brain, which can operate to shut or reduce these pain gates. I mean, certainly, if any of you have been to countries like India, and I assume similar countries, you will have perhaps seen people who can, just as an act in the street, take a large needle, for example, and I'm talking about something that long, and pass it into one cheek, through the mouth, and pass it through the other cheek, and then take it out, without apparently any discomfort. Now, what they're actually feeling, of course, we can't know, but certainly that it would be perhaps reasonable to assume that there is some kind of control going over there. Now, whether that control is coming from drugs, I would doubt in that kind of culture, or whether it's coming from some mental discipline, and so on and so forth. Something is certainly turning off the pain gate, isn't it? I think it's reasonable to assume that. And additionally, people who practice yoga in countries like that, and countries like this, you know, they'll go and they'll sit in a frozen tub of water and then thaw out wet towels that are wrapped around them, which I would assume, I mean, certainly for me, it would be jolly painful indeed. I'd probably be dead after the third towel, but they'll happily sit there and apparently happily sit there and do it. So there is some kind of controlling factor, so that it strongly suggests that there is some psychological factor that some people are able to control and other people can't, or other people don't know about, or it doesn't work in other people, in the same way that, for example, hypnosis. I mean, at one time, hypnosis was being hailed in dentistry as the new route to have your extractions, wasn't it? You know, people would sit there while they were having a tooth torn out by the root, apparently quite impervious to pain, without having a drug. So once again, something seems to be, to me, moderating to turning off those pain gates, those spinothalamic junctions, for example. So perhaps it's not all as simple as pain appears to be at the beginning. Obviously, drugs can work, although sometimes not as effective as we think they can be. I remember a few years ago now at hospital having to do a toenail operation on somebody who got a very nasty septic toe that was dripping all over the bed because they were in intensive care, and the intensive care were getting quite annoyed about it. But they'd actually had a brain operation, and they were wired up like a Christmas tree. And they were on a morphine driver as well for the pain. So we couldn't really shift them out of the ward that they were in. So we had to do an impromptu toenail operation, just a partial nail avulsion and pigmentization, something simple, to get rid of this nasty thing that could have caused all sorts of other problems, obviously in somebody who's healing from brain surgery. And I mean, this individual, they were drugged up to the eyeballs on morphine. But nonetheless, their toe was excruciatingly painful. And I remember giving them pretty close to the maximum safe dose of Scandinest in an effort to numb their toe without very much success. They still certainly found it very, very uncomfortable while I was doing it, so much so that we had the nurses poking their head around the screens that we got around the bed, saying, you know, what are you doing to this poor man? But nonetheless, so drugs didn't actually do very much for that painful situation. But I must admit afterwards, I did have a very nice letter from the person, apologising for making the fuss and thanking me for what was done. But nonetheless, you know, drugs in that instance, they didn't work very well. And obviously, you will, like me, have come across cases where drugs don't necessarily heroes. Then I would say this is probably one of them. Now, Paul Wisdom-Brand, he was British, although he became a truly international person. And he was a surgeon who was a pioneer in developing tendon transfer techniques for use in the repair of those with leprosy. And he was the first physician to appreciate that leprosy itself is not a disease of the tissue, but of the nerves. It's the loss of the protective sensation of pain and also the other things that nerves do, which, as we know, they control blood supply and all sorts of things, that makes sufferers susceptible to the injury that comes with leprosy and leads to tissue destruction, especially in the extremities. And if you want to read about his ideas on pain and how that works, I would steer you towards Pain, the Gift That Nobody Wants. And that was published in 1993. My copy is the 1997 copy. And that was published as The Gift of Pain. Now, this turns things on its head to a certain extent, because he makes the point that pain is actually a gift. Now, those of us, of course, once again, in our job, when we do things to the feet, we will come across people sometimes who have altered sensations in the pain, in the feet. So people, for example, like those who have diabetes, they might have peripheral neuropathy. Now, as we know, altered sensation can mean hyperalgesia as opposed to hypoalgesia. So they might be more painful, but equally they can be less painful. And sometimes pain or even sensation can be completely absent in the foot or a part of the foot. You know, some of us, we often tell the stories about digging drawing pins out of the bottom of people's feet that they've obviously had there for months and they've been there long enough to go rusty. Well, fortunately, some of those people didn't develop a life-threatening infection, but equally some do. And pain in that instance, it is a gift that they do not have. They're not able to protect themselves against the environment that we exist in. Because you can imagine if we didn't have any pain sensation whatsoever, then the slightest action, the slightest movement that we take, if that resulted in damage to our bodies, then that damage could spiral. There are, as you know, some children who unfortunately are born without the ability to sense pain at all. And they're very often, they're in a terrible state by after 2 or 3 years. And some of them, unfortunately, can't survive much longer than that.